Well, again, welcome to our last session here. And what we want to try to do is take what we've learned through the course of the meeting and begin to synthesize a plan. We've got a good idea here in patient and family engagement in general and shared decision-making in particular, lots of evidence that we can improve the quality of medical decisions and more evidence that we can bring better value to healthcare with this approach. But the challenges of taking it to scale face us. We've heard two presentations of different ways to do that, and we're going to focus on that really in our last session here as we get, again, your ideas on levers and alignment of incentives that we can bring to bear to make it easier to have more and more of these success stories. And it's my great good fortune to introduce our moderator for the session, Susan Denzer. She's a senior policy advisor at the Robert Wood Johnson Foundation, the nation's largest health and healthcare philanthropy, based in Princeton, New Jersey. In this role, she works closely with foundation leaders to carry out the organizational mission of improving the health and healthcare of all Americans. Susan's one of the nation's most respected health and health policy thought leaders and journalists. She's an on-air analyst on health issues on the PBS NewsHour. She's a member of the Institute of Medicine and the Council of Foreign Relations, and recently stepped down as editor of Health Affairs. Susan, we're fortunate to have you here, and I'll let you introduce our panelists in our next session.
Terrific. Thank you so much, Mike. Well, good morning to all of you. It's a great pleasure to be here. In addition to all the nice things that Mike said, I'm a Dartmouth grad, and I've known Jack Wenberg since I was a pup. And, of course, I edited a lot of the health affairs articles that we've seen today, and now at RWJ, which has supported the Dartmouth Atlas, actually, since its inception. It's a little bit of a homecoming for me to be here today, so thanks, Michael and others, for giving me that opportunity. So as I drove here this morning, I encountered what no doubt many of you encountered as you arrived over the last couple of days, which is the famous sinkhole that we now have on 14th Street, which, of course, being 2 blocks from the White House, we refuse to take as a national metaphor for what is going on with our country today. But as I drove over and saw the sinkhole firsthand, and then saw those concrete barriers that are basically protecting everybody from falling into the sinkhole, and the construction workers getting ready to excavate it and then pave over the sinkhole with what we hope will be a very nice new road on 14th Street. It came to mind that all of those were wonderful metaphors for what we are going to talk about now, which is to say, we have a big sinkhole, as we know, which is the entire chasm that we have in this country of overtreatment for patients who, if they were informed, would not have that overtreatment. The kinds of things that Jack laid out earlier, the notion of medical necessity being what you do if a patient is really informed and it also happens to be appropriate. We have a sinkhole of the opposite, in effect, going on throughout our healthcare system. We have a number of barriers, like those ugly concrete barriers that keep people from adopting the shared decision-making that we've seen over the last couple of days is such an important antidote to this, if you will, or a corrective for this sinkhole. We could actually fill this sinkhole with a lot of these strategies. In addition to that, we have the prospect of enablers for shared decision-making. The road will be paved over. The sinkhole will be closed, right? So as we go through our next panel, I urge all of us to think about the barriers that exist now, and that many of them have been identified already in this morning's discussion. Some of them are mental. As you see in the February issue of Health Affairs that we published, doctors have a mental barrier that this is going to take way too much time away from what the really important work that they do. Clearly, there's an undertone of it's going to diminish their authority if they just show somebody a video instead of giving them advice. I think also it's clear that a lot of physicians fear that this will demystify the art of medicine somewhat. I mean, if you can really just put it all on a video, why do you need them, right? So there are those mental barriers and other sorts of barriers. Another barrier that we identified in that health affairs issue was patients being afraid to challenge authority and ask questions of their physicians because they were afraid that the physicians would be mad at them, right? Actually, that was not that issue. It was a prior issue that we published. So there are all kinds of these barriers that we have to tackle. So let's think about what we do to tackle them. And, of course, the cultural barrier being among them. Then we heard already this morning about a bunch of enablers, how we pave over, create these new roads. And we heard already about new operating systems, CPOE, essentially embedding decision aid ordering right into the computerized physician ordering system, standing orders for decision aids, of course, payment reform, which would obviously be a very important enabler, and so forth and so on. So we've already surfaced a lot of these things. Now, as we go through the rest of this panel, let's think more about what is going to be necessary to take away these barriers, fill that sinkhole, and pave these new roads. So just to introduce our terrific panel who will be discussing this, first, we'll hear from Jeff Thompson, who is currently principal for Mercer and a senior healthcare consultant, formerly the chief medical officer for the Washington State Healthcare Authority, where he did both supply and demand side purchasing, policy development, and provider relations. And we've already heard this morning about the important role that Washington State has played in moving this discussion along. His prior experiences include having been corporate medical director for Weyerhaeuser, an associate editor at Milliman and Robertson, clinical assistant professor at the University of Washington in occupational medicine, and a general medicine officer in the U.S. Navy. So, Jeff, welcome. We're also happy to have with us David Downs, who's an MD who has practiced primary care internal medicine in Denver for the last 26 years and practices now half-time at Kaiser Permanente, actively engaged in the medical and health policy communities of Colorado as president of the Colorado Medical Society, also founding co-chair of the Medical Society's Physicians Congress for Healthcare Reform. And he's currently medical director at Engaged Public, which is a strategic public policy firm. So, Dave, welcome to you. Every other person today seems to be named David. So we have got two on this panel. That seems to be the minimum quota for a panel. So next we'll hear from David Swikowski, who's Senior Vice President and Chief Accountable Care Officer at Mercy Medical Center in Des Moines, Iowa. He is responsible there for developing a statewide clinically integrated network and leading efforts to achieve the AAA. Before his current position, he practiced family medicine and was the CEO of Mercy Clinics, which is a 155-physician multi-specialty group practice. We'll then hear from Lisa Weiss, who's Managing Director of the High Value Healthcare Collaborative Program Office at the Dartmouth Institute for Health Policy and Clinical Practice. You'll hear a lot about what the collaborative is from her, but I'll just tell you briefly, it's a consortium of 19 of the leading healthcare delivery systems that was formed to improve patient care, improve health outcomes, and reduce the cost of care by identifying, testing, and disseminating best practice care models and payment models among this group. And Lisa also serves as adjunct faculty for Dartmouth's Tuck School of Business Administration. And then finally, Kate Arisian-Chenok, am I pronouncing that correctly, is a director at Pacific Business Group on Health, where she leads innovation projects that focus on delivery system reform and payment redesign. She's also executive director of the California Joint Replacement Registry, which she helped to found, build, and now manages. And she'll tell us more about that, we hope. Her portfolio of projects includes a shared decision-making pilot in orthopedics, a pilot to demonstrate the use of episode bundled payment for maternity care, and a domestic travel surgery program for Pacific Business Group on Health members. That sounds like a really great way to spend your summer vacation, right? Traveling to get a surgery in the U.S., but not to be facetious, she will tell us hopefully a little bit more about how that works as well. Kate has more than 20 years of leadership experience with healthcare organizations in various arenas, including product development and planning and marketing. So with that, let me get off the podium here and turn it over to Jeff.
Great. So just some reference credibility. So I worked in the public system in both the federal and state now for almost 25 years. I've worked in the private sector for about 10 years. I've worked in academia, and it's all starting to look the same. We're all dealing with the same issues, but I do think there is hope. In Washington State, we've been through a lot of things, but we were actually able to manage Medicaid down to a 4% trend with a 20% growth. So I think you can actually do it, and I think shared decision making is a tool that we need, and I think it will help improve both the quality and the cost, as well as the safety and access. I would encourage you all to read the article that came out in Health Affairs. I think it's a really great article about, when you're not informed about the decisions that you sort of go down the path with a physician or a surgeon, you can end up down the wrong road. This is a gentleman who basically had the decision of just set the arm or do a more fancy procedure to set a fracture, and ended up asking whether he should just have the arm removed after several other surgeries. The issue, though, here is in my own experience, I've had an appendectomy, a cholecystectomy, sinus surgery, and I've seen, 3 parents, one in-law, die in the last few years. And it's just amazing how, it's actually kind of scary out there, both as a patient myself, because I try and step back and think about it, but as well as, just people that aren't as informed as a consumer as I am. And so the question is that if you want to do informed consent on anesthesia, the anesthesiologist that did one of my informed consents came up and said, well, Jeff, anesthesia is like walking across the street. That's the safety issue. Now, I'm a smart consumer. He didn't know I was a doctor. Am I going to counsel the guy who's going to be breathing for me for the next hour about how he didn't do informed consent correctly? Probably not. I just kept my mouth shut, said thank you very much, and bring on the propofol. So I'm a kind of really Sutton kind of guy, and so I spend a lot of time trying to figure out where I need to set my priorities. And one of the things I do is I use the cost. So I always find that when you look at cost, that's where you have the best opportunities to not only save money, to improve quality and safety. And one of the ways I divide the two populations up, there's the worried well, and we're doing a lot of work on trying to do weight and glucoses and blood pressure management. But then, and that really is what I call the 95-50. That's the 95% of the population that spend 50% of the cost. But the other side that we don't spend a lot of time, and I see a big opportunity for shared decision making, is in the 5-50 group. 5% of the population spends 50% of the cost. And it doesn't matter whether you're in Medicaid, Medicare, or the private pay. And I've seen this, and I'll show you what the difference is. And I think, Jack, I've used your stuff a lot over the years. The only thing is I wish we had a Dartmouth Atmos for each employer, because it's a little bit different. So if you're a retail operation, your cost is not an end-of-life care, because you've got a bunch of 20-year-old women. It's in obstetrics and NICU. Whereas if you're in manufacturing, it's in back and hip and knee surgeries, because these are all sort of injured workers. But obviously, if you're in Medicaid or Medicare, it's a little bit different. Medicaid delivers pays for 50% of the deliveries. But in Medicare, it absolutely is end-of-life care in the last 3 months. And so it'd be great if we had a Dartmouth Atlas for each one of these, so we could figure out then, what is the modular shared decision for each one of these. And I think, some of the things that, Ben and Molly in Health Dialogue we've got, some things coming out for obstetrics soon. One of the other things is that sometimes I don't think we're thinking about priorities. Now, you may not have thought, shouldn't we have a shared decision-making for immunizations? Now, that doesn't make sense, right? Because everybody knows immunizations causes autism and has a whole bunch of mercury. Now, I'm not kidding on this. Washington State has the highest exemption rate in the United States. We have endemic whooping cough in Seattle because of that. So we actually need decision support, both in immunization, smoking, and substance abuse. And so we did a study in substance abuse where we put actually an alcohol counselor in emergency rooms to actually do counseling and referral, and we actually saw it save money when they would go talk to the drunks or the DUIs. And yet that's not a best practice. And that's another form of decision support that I think has been very effective. And now we have codes for it, but we don't have the money to pay for it. When you look at the chronic care, this is where I see a set of tools. So I'm looking in the future. What do I want to give to an employer? I need a set of tools to deal with those chronic care issues, because that's the other 50%. So, and I don't think it's just shared decision-making. I think it's a whole set of, are we doing appropriate care and case management? AHRQ just released a care and case management tome and basically says it doesn't work. So we need to do assessments about, what the David said. Where are we actually defining where case management could go as opposed to giving it to everybody? Looking at informed consent. So the question is that, and I'll talk a little bit about definitions, at least the way I see it, is informed consent something the employer should pay for, the plan should pay for, or should the hospitals and the providers actually pay for it? Because that's what they're supposed to be doing, informed consent. And we've been talking a lot about how it doesn't happen. It didn't happen with me in anesthesia, quite frankly, and in all the sort of consumerism I've had to do with myself and my family, I haven't seen a lot of it actually happen really well. But I think you also got to look at second opinions because people are scared out there, and there are now services where you can actually call up, the East Coast docs are best. Did you know that? Best docs is East Coast docs as opposed to West Coast. I haven't figured that out yet. But in any case, these are tools that we can give, and I think, people are scared out there. I'll talk a little bit about it. I think there has to be variation control, and what people talked about is policy leadership, because you got to mix all this in. When you find outliers out there, like in the state of Washington, our NTSB C-section or low C-section rate is between 14 and 40%. 14 and 40%. It doesn't matter which hospital type you are. And we need to start getting the policy and the employers out there and talking about who's best in class and who's worst in class, because it all has to be in the mix here. And quite frankly, employers are getting bold enough to say, you know what, if we can't see transparency in cost and quality, we're willing to just basically ship it out. So Boeing, Lowe's, and Walmart now have centers of excellence that say, we'll take the member and we'll take their spouse and we'll fly them off to someplace because it's better there. And they're getting bold about this. And so this mix of services is one of the things that, I want to talk a little bit about. So, patient decision aids, shared decision making, it seems like we're having a little bit of difficulty really understanding, at least in the market that I see, what it is. And it really should be evidence-based. And I really want to laud David and Group Health and some of the other David, activities that we need to actually develop evidence, because I see a lot of tools coming out and they're fluff. There's not a lot of evidence, and I'll show you an example here. And it really should be something like this, at least in my shared decision should be something around which is better, A or B, and then looking at the harms and the benefits, using the IFDOS standards to basically say we want these checkoff tools to basically say, where should I go? Should I get my prostate out or not? Should I have my breast removed if my BRC 1 and 2 are positive? Should I, all these things need to be looking at options and risk and benefits. And doing some of those things where we look at, the bodies and what happens, because it's getting complex. Let me give you an example here. So in the state of Washington, we're seeing these huge variations in spine care. It's about a 50-50 chance that you're actually going to get better, less pain or more pain, and we don't even talk about function. But we're actually looking at smoking. And did you know that if you are a smoker, you have a fourfold risk of effusion failure? And I've seen none of the decision aids actually talk about this, even though it's in the literature. So that really, to me, is what I think a patient decision aid is, and using those IFDOS standards around content and development and effectiveness to have all the checkoffs. But I know what's going to happen is new, bright, and shiny, expensive is going to come out before old, rusty, and works. So whereas consent tools are more of, I've already chosen, what I want to do. I've chosen B. Now what happens, pre-surgery, during surgery, and post-surgery? But when I've looked at most of the tools out there, they got great descriptions of fusion, but they just say you shouldn't smoke. Not you have a fourfold risk. And oh, by the way, in the state of Washington, we have surgeons which will never operate on a smoker, and we have surgeons where 40% of their operations are on smokers with back surgery. 40. So 40, and if they're 50%, that's another 50%, that are going to fail. And so that's why I think the shared decision making ought to actually be, and I think what one of the Davids talked about, variation control, bring it out to the physicians and get them engaged in both practice management as well as shared decision making. So, and that second opinion is another thing that I think happens, and it's happened with my family. People are scared out there. You know, when I had my appendectomy and I actually diagnosed myself with acute appendicitis, you know, I wasn't thinking that he didn't do a rectal exam on me to see if I had a rectal cecal appendectomy, or appendix. You know, am I going to counsel the provider on the appropriateness of what his physical exam is going to be? No. You know, when I got done with my exam, actually he was going to discharge me from the hospital until he asked me what I did for a living. I told him I was a CMO for Medicaid in Washington State, so let's get a CAT scan. The variation in CAT scans in adults in acute appendicitis when I had it was between 20% and 80% because I saw the CHARS data. So I think in these things, you know, people really need access to second opinions. You can buy it, but who is the best second opinion? You know, when I have a question about what worked or didn't work, who do I go to? Because it's a very difficult dialogue to talk to your physician or surgeon about that, especially when it didn't work. You know, and so, you know, I want to have a fusion. What things should I be doing and who should do it? Should it be a health coach? Should it be a nurse? Should it be another surgeon? So these are these kind of things. So, you know, and then the second, you know, the centers of excellence that are happening out there, are we going to actually start shipping people to whichever is ever better? And do we have actually the public transparency about who is actually better out there? Well, I can tell you the employers now are basically saying, if you can't show me your value and cost and quality, we're going to do it for you. And that seems to be kind of the mantra these days. And so that's sort of the mix of services. You know, the last thing I want to talk to you about is why I think shared decision making, I don't know if it was talked about yesterday, but I think it has a role in liability reduction, especially in Washington State, because when you look at some of the studies, and it's hard to find studies on liability, you know, it's diagnosis that actually is one of the problems here, you know, in actually why doctors get sued. And so one of the questions is that, you know, in the state of Washington now with our state statutes and codes, how can we introduce shared decision-making into liability reform? So I've been talking with liability carriers about, you know, looking at, as our statute says, if you do shared decision-making, and if it is certified by the healthcare authority, the liability standard goes from clear and convincing, or goes from preponderance to clear and convincing, or 50 to 75%. But I haven't found an insurance carrier yet that's willing to say, I want to do a premium reduction with shared decision-making, because they're actuarially looking at what their liability risks are, and until you've actually can show it, or there's actually been a court case, we're not actually going to, you know, do any kind of reductions. But at least in the state of Washington now, we have a process. We're using the IPSOS standards, and so if we can get something certified for both the self-insured or as well as the liability carriers, that's another sort of value proposition that I see for, you know, a shared decision making. It will actually reduce liability. Yet to be proven in courts, though. So yeah, it was a real quick talk, but I only had 10 minutes. But thank you very much for inviting me. And you know, I'm hopeful that shared decision making will become standardized. I really would like to see it evidence based, and I would like to see it actually very inexpensive, because you know, it's easy for a very large, you know, employer or health plan to pay for it. But I think we also have to remind ourselves that 95% of the population are employed by small businesses, and they don't have a lot of money for this. And so the more we can make it cheaper, I think the better. So thank you very much.
Well, thanks very much for having me, and I also want to thank Meg and Richard and others at the foundation that have been a big help in the project that we're doing now. The project I want to talk about is a little different than some of the other ones. We are working on development of insurance benefits. Actually, hang on a second here. Insurance benefits to kind of address the patient side of the supply-demand equation. A lot of what's going on now is on the supply side, and I'll talk about that in a second. But we really felt that the demand side is in some ways neglected and critically important. So engaged benefit design is just kind of how we branded what we're doing. The vision, we're in Colorado, so Coloradans will be the wisest consumers of healthcare in the country. It's a little self-serving too, because one of the big foundations that we're applying to a grant to wants to have Coloradans be the healthiest people in the nation. So we thought, if we were in alignment, it would help, and actually it did. So, Engaged Public is a public health or a public policy firm. We have an emphasis on healthcare, but also education and some other areas. So, as I said, the big question is, why would we want to take a different approach to insurance benefits? Most of the incentives that are out there currently for improving quality and value, and I just learned yesterday that was not PC anymore, so I'm sorry there, but most of the incentives that are out there now are directed toward the provider population or the supply side of the healthcare equation. So pay for performance, everybody's familiar with. Patient-centered medical homes actually are rising and showing some proof of concept. Accountable care organizations, I think, at least as evidenced by Group Health and Kaiser and others, are probably a good way to do it, particularly if you can virtually organize the smaller private practices into functional units. And bundled payment, I think, is going to be a good way to kind of transition from fee-for-service over to something more like an accountable care organization that operates with a global budget to manage a population. But incentives on the patient side have been pretty indiscriminate, and they've been aimed primarily at cost. I don't think anybody's made a major effort to change the incentives for patients to seek higher value care and to avoid unnecessary care. So high deductibles, cross-board increases in cost sharing are common. The only other way that you can shift more costs over to patients is to raise premiums, which drives people out of the market. And the net result is that you reduce some preference-sensitive and supply-sensitive care, but you also reduce the utilization of effective care with potential worsening of health outcomes. So the basic structure builds from something called value-based insurance design. I know the health plan people know about this. I'm not sure other people do. But the idea, at least in the iteration that we're doing, is to identify a specific list of high-value effective services. So these would include screening, prevention, good chronic disease management, prenatal care, and essentially eliminate the cost sharing for those services. And then at the same time, in part to reduce unnecessary care, but also as a cost offset for providing more care in the effective category, we identify specific high-cost preference-sensitive services and increase the cost sharing. Try to avoid increasing it so much that it's a barrier to care, but enough to send a price signal to consumers that it's really worth taking a deeper look at the issues. We borrowed heavily from the Oregon Health Leadership Council, so I think my friends from Oregon. They did very good work at identifying a couple of lists, and we built largely from that list. We used multiple sources of best evidence and comparative effectiveness, including Washington State. You guys did a good job with your health technology reviews. The project was funded primarily with either government dollars or philanthropic dollars. We got a grant initially from HRSA through our Medicaid agency in Colorado, and subsequently, in order to weave shared decision-making in, got a grant from the Robert Wood Johnson Foundation. And then we spent about 18 months with a group of prominent physicians, some insurance experts, the business community, consumer representatives, had these kind of marathon meetings that lasted 5 or 6 hours every 6 weeks or so, and ultimately came up with a proposal that everybody was comfortable with. And then as we started out basically just with that, and as we moved forward, particularly Gene Kuttner, who is one of the content experts for the foundation in the area of palliative care, but who also was participating, suggested that we start looking harder at shared decision-making, particularly since we were dealing with preference-sensitive conditions and asking people to look a little harder. It made sense to give them the resources for that. So we've been using the decision aids in our pilot, which I'll tell you about in a second, the foundation aids, which have been great. In our current pilot, we give a $50 check to patients If the decision aid is ordered by a provider, and if they go through a pre and post questionnaire that I think Karen Sapuka, wherever she is, developed to assess their knowledge score and readiness for decision making. We've talked with other people about other strategies to provide incentives for patients, including people who think there shouldn't be any incentives, that it really should just be the thing itself that sells patients. There's another implementation that we're just bringing up now in Grand Junction, where they're planning to waive the co-payments for those preference-sensitive services when patients go through a shared decision-making process. We've also thought about wellness points. This strategy overlays well with wellness programs. The infrastructure in place for those is good. And so, for instance, there are these things called health incentive accounts, where if a patient completes a health risk assessment, or if they bond with a primary care doctor, if they participate in wellness programs and chronic disease management programs, that they actually get funding into an account that helps them with their co-payments and deductibles. And then we felt it was very important to assess the experience that patients were having with patient decision aids, and so the foundation is working with us. We have an electronic platform where we can upload data from pre and post PDA surveys with the patients, and they're helping us with our data assessment. So the current pilot, as I mentioned, is funded through HRSA and Robert Wood Johnson grants. The run time for the pilot is between January 1st of 2012 and the end of this year. It's in a rural area of Colorado, the San Luis Valley, which is in southern Colorado. It's a very well-defined geographic region, which is one of the reasons we went there. It's got a mountain range on either side and New Mexico on the south side. There are about 50,000 people that live there, and it's about the size of New Jersey, so it's a fairly diffuse place. The pilot employer, and we're going through employers at this point, is the San Luis Valley Regional Medical Center. We've got about 725 people enrolled who are all the way from housekeeping up to the C-suite. And to date, we're almost three-quarters of the way through. It's actually been very well received. And we're starting to see some cultural shifts, some expectations, both on the doctor side and on the consumer side, that shared decision-making be part of how they go about delivering care. So the lessons we're learning, and this has come up several times, and I think this is the single biggest barrier to moving all of this forward, whether it's a big integrated system or it's a small employer, is really changing the culture. So we've kind of looked at this from the beginning as a cultural intervention, and hopefully it will continue to do that. We found that outreach to consumers and providers in the early going is critical, and I can talk about that if people have an interest downstream. I do think the patient incentives help. We have initially seen patients coming in because they want their $50. They go through the process, but then they're asking for decision aids that are not incented with that. Services that are not on the green bucket list or the red bucket list, as we call them, don't get an incentive for the decision aids, but the decision aids are there. People have a healthy appetite for them now. Once using the PDAs, the initial complaint we got from providers was, how do I know that this is evidence-based? All the usual questions. It's going to take too much time. My patients won't appreciate it. As we've gone forward, the only complaint we get from providers now is, why can't I just use this with everybody? And so that's a barrier that we're hoping to get over at some point. And then also that a dedicated resource center is key to making things work, because there are a lot of functions that need to happen. There needs to be a librarian function. Somebody needs to administer the surveys. Somebody needs to capture the data. And somebody needs to provide feedback to providers once those surveys are done. Somebody needs to send information to the TPA that's administering the benefit package. And all those things, it turns out, are being done in this project by a nurse who has 4 hours per week dedicated to it. And it's worked very well. She's also been one of our great champions for getting the clinics involved. So next step, we did get a new grant. We want to try to identify and assist more larger groups to be insured. We're looking at the Colorado State Retired Organization, the Public Employees Retirement Association. In Colorado, Medicaid is now moving toward accountable care collaboratives, which are organizations trying to tie together and integrate the care that's delivered to Medicaid recipients. We want to see if we can start integrating shared decision-making in with those groups. We want to try to create a regional shared decision-making resource center. If people have not seen the section in the Affordable Care Act that deals with shared decision-making, it's Section 3506. It envisions these decision centers that provide decision aids, develop them, certify them, provide curriculum to providers, make them available to communities. And I think someone mentioned earlier the need for having this become a community-wide thing. So that's one of the things we're hoping to accomplish, at least in a demonstration sense, with this current grant. And then we want to spread it across the entire San Luis Valley and perhaps beyond, make the decision aids available to all the people in the valley and experiment with different ways to distribute and advertise and educate people about the availability of them. We're also working with our new cooperative that's brought up under the Affordable Care Act. We're working with them on benefit design and then community engagement around the concept of a medical commons, which we feel very strongly about. So thanks.
Thank you so much.
I'll just go on to the next one. Great. It's my pleasure to be here. I want to start. I'm Dave Swiskowski with Mercy Medical Center in Des Moines. And I want to start by thanking the foundation for their support over the last 4 years, really with shared decision-making for us. So we had an opportunity to have resources available to help us implement this and the educational value and teaching that we learned from them. We started doing this project in our quality department for our physician group, a 150-member physician group, and then in the last year we formed an accountable care organization in Des Moines and moved all the quality department into the accountable care organization and all their staff into the accountable care organization. So now the accountable care organization is responsible for implementing shared decision-making in our organization. And it's interesting, if you look at the Medicare Shared Savings Program's criteria for acceptance, you have to show and demonstrate how you're doing shared decision-making. And I've spent a lot of time now going around and talking to other accountable care organizations and going to meetings of accountable care organizations. Shared decision-making really doesn't come up at those agendas right now. And I think that makes sense. There's really a million things we're having to do and regulations we have to do. And we're focusing on other things maybe more so right now. But in Des Moines, we really are focusing on shared decision-making as part of our accountable care organization work. And we might be a little unique in the amount of effort we put into it right now for an ACO. So just a little about where we are from and what is going on in Des Moines. Our health system in Des Moines, CHI, is owned by Catholic Health Initiative, so we're CHI Iowa. Our large medical center is 627 beds. 31,000 admissions, and in our outpatient clinics, about 1.4 million visits per year in our outpatient clinics. We have very busy outpatient clinics. Our providers all operate in close to the 90th percentile in productivity. So it's probably related to a lack of supply in Iowa. So a year ago, in February 2012, we formed our ACO. We now have enrolled 657 providers in our ACO, and it's about half, a little more than half specialty, but almost half primary care in our ACO. We have 26 adult primary care clinics, 6 pediatric clinics, so again, focusing on primary care, and 62,000 lives that we have under shared savings contracts. So we have a commercial contract, we have a Medicare contract, and we have a small Medicare Advantage plan. And we have our own employees now in a shared savings arrangement. So we do have the incentives being redesigned for our group. we do anticipate that within 2 years we'll have over 50% of all of our patients in shared savings contracts or some type of value-based contracts where there's a connection between the value and not just the volume of care we're delivering. Go on. So we're working to advance the shared decision-making between our clinicians and our patients, and we're working in two areas. One is the physician engagement. We think it's important that they have to have the physicians involved. They have to know what's going on with this. But the other part is the utilization of our resources and actually our system redesign. We think we have to change the systems that physicians practice in. It's not enough that you just educate the physicians. The reason physicians don't, I don't think it's a hard sell for physicians to tell them that decision aids are important. The reasons they don't use decision aids is the same reason they don't do preventive screening and they don't do all the other things that they don't do. They are in systems that are perfectly designed for them not to use decision aids. All the incentives are for them not to use them. They don't get paid anymore. Our doctors are all very stressed for time. They all have more demand for their time than they have ability to meet, and so they're very busy. They really don't have time to add in 5 seconds for shared decision making. Another thing that we did early on is we did shared decision making on knee and hip osteoarthritis, and the problem with doing that one in our practices is the average family practitioner is probably going to have 5 patients have surgery for knee or hip osteoarthritis. They really couldn't remember for that one patient, every 2 months, I got to get that decision aid out for that one patient. So you have, if you had enough volume, we find things where we have a lot of volume and the doctors get exposed to it regularly. They kind of will begin to uptake on these things a little quicker than they otherwise would. So you have to have enough volume to do it. But what we really kind of decided is after you have the doctors involved and at least knowledgeable about what's going on so they can support it and talk to the patients about it, then you got to build the system around them to deliver this and make sure that the things that you want to happen. So for the physicians, we have quality committees, we have governance committees, and we went to them and we got their support, we got guidelines and administrative support for this. We identified champions in all of our clinics to lead this. So we had a physician we could go to and say, hey, we got this project, will you do it in your clinic? And they would. And then we went around with academic detailing. We took the little coffee carts actually, and we did cappuccinos and those kinds of things at every site. And we'd sit there all morning, and as the doctors would come up to get their coffee, we'd talk to them about shared decision making. So we did them one-on-one. We did them in small groups. So that's how we got the physicians involved in this. We also, I don't have it here. We had CME events for physicians also. So then the ACO is working on changing the system. So things we're doing, so we have the decision aids and we'll distribute them to the practices. So they tell us which ones we want. We make sure that they're there and they have those decision aids. And different clinics are focusing on different decision aids. And we're encouraging them that you want to use these, use them, and at least they learn the process. They don't have to learn every one, but they get one. Maybe they'll start migrating to a second one. We're sponsoring our CME events, and now we have 2 new specific initiatives that we're launching, specifically from the ACO point of view. So we're doing advanced directives, and we first took the approach of trying. We have health coaches in the hospital who see all of our ACO patients while they're in the hospital. So our first approach was to try to address people in the hospital about advanced directives. That just failed completely. Patients were overwhelmed in the hospital. They get all kinds of information, and giving them another piece of information when they're in the hospital really was not much value. So now we're focusing on the first visit after hospitalization and getting the shared decision aids to the patients at that point. And so we've just been doing that for about a month, 6 weeks or so. So we're hoping that's going to be a more effective way than doing it in the hospital, which for us at least, did not work. And the other thing we're working on is colon cancer screening. We know as an organization we do not do well in our colon cancer screening. Part of it is we can't get people in the GI doctors to do colonoscopies. But we're working on that. We're bringing in more GI doctors. So we are now doing a project where we have identified 2,500 patients who need colonoscopy, or need colon cancer screening, I should say, or have not had it, are eligible for it. And we're sending half of them the fecal occult blood test kit, just the kit, and a cover letter. And we're going to send the other half of them the kit plus the colon cancer screening decision aid from Health Dialogue. And so we're going to track to see what kind of responses do we get from the patients. You know, do they are more likely to return the fecal occult blood test, or are they more likely to schedule a colonoscopy after that? So that's an initiative that we hope to have the mailing going out before July 1 is what we're shooting for on that. So we're looking at these things that we think align with the things that we're working on in the Accountable Care Organization. We are developing care management software so we have 30 coaches throughout our organization. So they have care management software, and we're developing this care management software from scratch ourselves. So we're building the shared decision making in there. So when they order the decision aid, we know they ordered it, and then the steps in the decision process and follow up after that are all in there, so we know if they're being done or not being done. And then finally, we're really engaging our health coaches and promoting shared decision making, and I kind of alluded to our coaches already, so I'll talk about that. And this is our key delivery system redesign. I maintain if you don't change the system that these doctors maintain, and you're not going to change the behavior that you're getting from these physicians. So we're working on changing this delivery system with our health coaches. We have at least one full-time health coach located at each primary care site, so they're physically located in the site with the physicians. They used to actually be employed by the physician group. Now they're employed by the ACO, so we want to direct their work to do the ACO work. They spend a lot of work on self-management support, motivational interviewing type stuff, and connecting people to community resources. They do coordination of care, and the thing we're focused most on now is that transition from the hospital back to the clinics. We track all patients at the time of hospital discharge. We know when they've gotten back to the clinic or if they didn't get back to the clinic, and have protocols that we follow to follow them up for the month after a hospital discharge. They work on quality improvement. Our coaches have time in each clinic to proactively work on quality improvement projects, and we meet together every 2 weeks to share what we're learning in different clinics. And then they do the shared decision making. So because of their work in quality improvement, they were natural to do it, the shared decision making. They initiate new projects in our system. And so all of our coaches have gone through pretty extensive training in using decision aids and assisting patients with making decisions. So they are the leads in their clinics to identify patients, to distribute decision aids, and to follow up after they're done. Our coaches do pre-visit review of every patient before they come into each clinic, so that they plan the visit. So if they need any testing done, the testing's ordered before the doctor sees them. If they need a referral, the referral's ordered before the doctor sees them based on standing orders. And likewise, if there's a condition where the decision aid will be a benefit, they can distribute decision aid before the physician sees them. So that's kind of how we put the process in place to assist the doctors in getting this done rather than asking them to get it done themselves. So, why are we interested in this with an ACO? And we think that shared decision-making really aligns with our Accountable Care Organization goals. We believe fully informed patients have better outcomes, and that people with better outcomes are going to have lower total cost of care. I heard I missed on the meeting yesterday, but I'm hearing rumblings about, don't talk about the cost. I'm sorry, in the ACO, we talk a lot about the cost. And, because frankly, if we don't cut the cost, we don't exist. So our mission, so the word used to be no margin, no mission. Now it's no outcomes, no income. So, you need to start measuring these outcomes, and among the outcomes are cost of care, because that's what's going to allow us to do the good things we think we're going to be able to do. So we're not ashamed of talking about cost. I also think that cost is one of the best markers for quality. If you're really improving the health of the populations that you're taking care of, the cost of taking care of that population is going to go down. And if you're doing all this good work and you're not reducing the cost of care, are you really making a healthier population? So we use cost as a metric of quality in our organization. Shared decision-making is very patient-centered. One of our core values that we have for our ACO is patient-centeredness, and we think that this is very congruent with that value, and makes me want to make it part of our strategy for our organization. We're convinced it's going to increase patient satisfaction, which we're being measured on, and we think it can distinguish us against our competitors in the marketplace, make us unique and be of value in that regard. So lastly, what do you need to make shared decision-making a sustainable part of day-to-day healthcare? I think you do have to make that quality case first and foremost. You have to go, if it's not going to make healthier patients, then it's not worth doing. But you also have to make that value proposition. You got to find out exactly who's going to get that value. In the case of the Accountable Care Organization, now finally, we think the value stream is going to go for us. And our Accountable Care Organization is run and organized by our doctors. And so now we feel we don't have to go and ask for someone else, gee, if you'd only pay us for this, we could do it, or we could finance this. We don't have to go out and get grant funding and say, they support us. We now have a sustainable mechanism, if we are successful in reducing the cost of care, to continue the shared decision-making. And then lastly, I think to make this successful, you can't increase the work of the physicians. Our physicians are struggling to get through every day. They literally do not have an extra 5 seconds per visit, and there are literally 20 organizations telling us, if we only had a few seconds of your doctor's time, we'd do such good work. It doesn't exist. So you have to figure out, if you're going to do this, you have to make the argument, how do you save time for the doctor? It's not even being time neutral. If you want to introduce this, you have to convince them it's actually going to save them time over their previous ways of doing their work. So that's our story of Mercy ACO. Thanks.
Okay, good morning, everybody. I'm honored to be here among all of the thought leaders of shared decision-making and practitioners. I am the Managing Director of, and I'm Lisa Weiss, Managing Director of the High Value Healthcare Collaborative, under the leadership of Jim Weinstein, who's the CEO of Dartmouth-Hitchcock Medical Center, many of you know, and David Wenberg, who, in addition to all of the accolades Dave Viroff gave him, wherever Dave is, for his work at Health Dialogue, he also, as another David, has the credentials of always being introduced as Jack Wenberg's son, which I find quite humorous. I've actually listed out the topics Mike asked me to talk about, so I'd make sure to talk about all of them. So what we are doing as HVHC, I will first, as Susan mentioned, give you just a brief overview. There's not a lot of time to go into this, but we are a consortium of 20 health systems and growing. We've just approved a couple of others, and you can see we're all across the country, not quite as much into the southeast as we would like to be. And we have come together to share data, use that data to conduct analysis and compare our performance, and I apologize, I have to use the word value, it's right in our name, value-based metrics. So we look at a comparative analysis of quality, outcomes, and cost to help us identify best practices that the better performers are engaging in. And that's a little bit of what makes us different than other collaboratives that are just sharing data and doing benchmarking. And I think this is really important to understand about HVHC, which is our nickname for High Value Healthcare Collaborative. I'll start calling it HVHC. You can make the V whatever you want then. Get virtuous or something. Just don't make it high volume. We not just do the benchmarking, but we're very hands-on and working with each other to not only identify those best practices associated with those better metrics, but then we take them and spread the tests of change to other organizations in the collaborative to see if it actually works, those models, those care models work in other environments, and then actually push their metrics. And so we've had some good luck with that so far. But we're just beginning. We're only a couple of years into this. And by the way, I should mention, as everybody has, I think many have given Jack credit here for the work that many of us are doing. This collaborative, even though it has only been in place for a couple of years, has been in the making for more than 10 years based on work that Jack started with Mayo and Intermountain, but we've only just made it official for the last couple of years, and we're making great progress. So what I'd like to talk about in terms of the work that we are doing around shared decision making very much is based on a CMMI award for the Center for Medicare and Medicaid Innovation. It's an innovation award. It's the second largest in the country, $26 million. A good portion of that is to fund shared decision making. I will say that while it sounds like a lot of money, if you spread it across 15 organizations over 3 years, it actually doesn't end up being one of the largest compared to the others. However, it's been a great initiative to help us take the edge off of other costs that we were all doing as a volunteer organization. And the goals of this initiative really are to continue the work that we had been doing, which is to improve the AAA, quality outcomes and cost of care, by advancing those best practice care models in these cohorts of hip, knee, spine, patients with diabetes and CHF, and then we actually had an add-on of sepsis at the, it's a little of an outlier there, but it was at the request of CMMI. And then the second really, the big goal here is to improve the patient experience and reduce utilization and cost. And I'm going to focus quite a bit on cost. I've heard a number of apologies about focusing on cost, and I feel the same way. It is a very uncomfortable topic for us to be talking about. And in fact, we were up late into the night last night trying to get our members to commit to cost savings targets. And the way we're defining cost here is Medicare cost. So that's important to point out, Medicare reimbursements. And it's a very controversial topic. And so while, of course, the patient voice is very important and it is a high priority, and patient satisfaction and quality is very important focus of ours in shared decision making, it's so convenient and so exciting that shared decision making also has this nice byproduct that I won't describe because others before me have, of reducing utilization and rates because of the reasons people have named before me today. So that's why I think the shared decision making initiative is one of our most exciting prospects so far for HVAC because of that nice benefit, and we do have to focus on cost. But that doesn't make it any easier for our surgeons, particularly, and our CFOs for our members' sites who are debating with us still today. Right here, that they live in a fee-for-service world, right? And we are helping ourselves to prepare for the future of risk-based contracts and shared savings, but right now they're still in a fee-for-service world, so it's a very hard thing. Unlike the group health presentation that Dave gave, it's much harder for us to get that aligned right now. So that's one of our biggest challenges. So we are focusing on classic shared decision-making for preference-sensitive decisions for the hip, knee, and spine surgeries, lumbar spine surgeries. And then for chronic care, this has been a little bit of an interesting learning point for our members and for CMMI, that we really have to broaden shared decision-making to be the broader aspects of patient engagement, to include some of the more traditional care coordination, motivational interviewing. The discrete decisions are really a subset of the broader patient engagement. So that's been a little bit of back and forth for us as well. The shared decision-making components for those that we'll focus on are the decision to have insulin, and then for CHF, an ICD insertion for work that's coming out of University of Colorado. So again, I'd like to just point out that while we are really focused on patient experience and patient care, our goal for this initiative and our mandate from CMMI is very much focused on cost. And before we started this work, if we think about our cost being really the equation of the cost of an episode of a care multiplied by the number of times you have that episode, before we started the work that we're doing now, we really had started our focus on the episode cost, so the variation of how efficient an episode was. And in fact, when we had our first publication, and this was around total knee replacements, when we had our first publications in Health Affairs, for those of you who know Jack Wenberg, you won't be surprised to hear this. I showed up to the office all excited about our publication in Health Affairs, and he said, You're focusing on the wrong thing. I think I'm going to call you the low-value healthcare collaborative because he thought we should be focused much more on the shared decision and rates than trying to squeeze out some of the efficiencies. But both are important. And so what you're seeing here, and obviously you can't read it, but from a visual standpoint, you can see that from the data our members sent us, so they send us data from their billing systems and their EMRs and labs, and then we're also getting data directly from CMS. But this is based on data they sent us. You can see the huge variation, not only in the total, those are post-acute reimbursements for total knee replacements for 60 days, I believe. So not only the variation in total, but the colors represent the variation of the types of costs within those. So it's a huge variation. And then over on the right, I've actually got a bigger picture of this. I won't dwell on the topic here because Jack obviously did a better job than I could in talking about the variation in these turnip plots. But I will set the stage here to say that these are our HVHC hospitals within our 15 members at the time of the award are participating. The gray in the background are the hospital referral regions, and the red dots are our hospitals. And so you can see a great variation here from below 4 to 20-something knee replacements per 1,000 beneficiaries. And then this variation on it, again, hard to see, but we took the top, all of our members who had more than 3 hospitals, some have fewer, but for those who had more than 3, we took their top 3 hospitals and made them the same color. So you can see, if you can see over there, like just look at the yellow, so you can see that there is variation within a hospital system, an extreme amount of variation from hospital to hospital within the same health system. So it's really interesting. And by the way, that's not a typo up there above rate. That is a real variation. And of course, because if you know David Wenberg, they have already done all the right adjustments for outliers and things. So this is a real variation here. And we took all the small ends, hospitals that had fewer than 1,000 beneficiaries out and that kind of thing. So that is a real variation. So what are we doing to make shared decision making a part of our day-to-day health care? I found it interesting as I was listening to Christine's keynote yesterday that I had already given my slides here, and 3 out of the 4 of ours matched of the 4 things that she named as being important, and in different words, of course. So we've got a lot that we're doing behind the scenes and a lot of details around this, but I just wanted to quickly go through what I think is going to make this not just doable in the short term for our 15 members trying to implement this right now, but also, as you imagine, we are still growing, we're trying to continue growing, and so we're going to bring new people on, so we need to make this scalable, sustainable, and do it at a pace that doesn't take as long as it's taking us, because as you all know, and we've been talking about for 2 days, it's really, really hard work to make these disruptive changes in an organization. So the first, and I'll go through each one of these, we're doing work to transfer shared decision-making process. And many people here have talked about this, that obviously the patients are doing it on their own time. One of the things we're trying to encourage is that not only is it on their own time, but it's at home, over the web, and there are advantages and disadvantages to using the web, and I know a lot of people love the DVDs, but again, when you're thinking about the volumes that we're trying to do and the spread that we're trying to achieve, and we are not able to do the hands-on work that some people have done before. We're removed from the physicians, so we can't even make our own plea to them. So one thing we've done, and you heard yesterday Charlie's work and Dale's work, they gave my disclosure about my work with dynamic clinical systems, and that's how I got first exposed to shared decision-making, was on the patient-reported measurement side from the work that came out of Dartmouth with Jim Weinstein. And what we've done as part of this project, so they've continued on working with TDI, DCS has, and I'm no longer with them, but they have made a much lighter version of it it's easier for TDI's work, where they're working with a number of Beacon and ONC demonstration projects. For our project, we have been working with Health Dialogue to integrate the pre and post questions into the Health Dialogue videos. So patients have a much easier way to just receive a token, sign in, register themselves, less burden on the clinic than some of the work we were doing previously, and then automatically go in and watch the videos from Health Dialogue, and then answer post questions about their knowledge and their preferences. And some of the reporting that you saw yesterday out of Charlie and Dale's reports. So one of the things, I won't repeat what they already showed you. I know I'm running short on time, but one of the things I will point out, so this is a report that comes out after the patient has watched the video and answered the questions. So there's some information about them compared to others, and the doctor can also view this, or the health coach. But then, and that's not very clear, but to blow it up, we do have information that helps the health coach understand how ready that patient is to make the decision based on which questions they get right or wrong, or as Dale and Charlie were alluding to yesterday, the graphs that show the concordance between a patient's preferences and the decision they made. It may not even match. So that's one way that we're working on that. The other way that Christine alluded to yesterday is not just that measurement and feeding of the data that comes out of the individual patient experience, but then at an aggregate level to continue measuring and monitoring the patient experience and feeding it back to the reluctant people that I won't call physicians. No, just kidding. In our case, it really is the surgeons who are feeling like, and actually there are some patients too. As someone mentioned, I think it was Neil mentioned the rationing. And we have, out of one of our implementations in Utah, gotten a lot of pushback from patients feeling like that implementation is about Obamacare and rationing. So we think it's really important to continue to feed back all these positive patient experiences that you've heard from earlier presenters. And so this is my last slide. One that I did not make a slide for, but was one of the four, is we are working to build health coaches into the process, and I've heard other people talking about health coaches here. At Dartmouth-Hitchcock, that was not a way that they were doing shared decision-making. It was just really a logistical, I don't mean to say just. It did not have health coaches involved. So one of the big parts of what we're doing here is introducing health coaches into the process, and whether it's by phone or in person, and giving them that, in some cases, a provisional referral is one of the, and I heard someone else talking about that today, moving the decision upstream into primary care where possible. Not everybody's doing that, and that's one of the great things about having 15 members working on this. Some of them won't be able to move it in primary care or do the provisional referral, but we're going to be able to compare all of these natural experiments and see how it works. So we're really excited about the health coach piece of that. So as my last slide, again, these are our award targets, and we think these are pretty low bars in the improving care piece, getting at least 50% of the eligible patients to be referred to shared decision-making, and then of those, at least 50% of them complete the shared decision-making. I think that's a pretty low bar. And then improving health, of course, is part of this, and then our focus on reducing costs, that we have a commitment to CMMI to reduce our costs by $64 million over our 15 health systems, and they are taking this very seriously. So, and it's not just coming from shared decision making, but a big part of it is we are hoping. So that's it. Thank you very much.
So thanks. Sorry, a whisper. I'm Kate Chennock from PBGH, and thank you for inviting me. hopefully last but not least, and the foundation asked me to talk about purchaser perspectives, and I think that Jeff and David did a nice start on that. PBGH, for those of you who don't know it, is a business coalition of very, very large businesses. 25 years ago when it was started, many of them were actually located in California, which is why it's called the Pacific Business Group on Health. But now you can see we have the Walmarts and Boeings, and we have CalPERS, which is definitely a West Coast organization. And the clicker is not working. Do it by hand? Let's do it this way.
You just use that.
The arrow. Thank you. Thanks, Lisa. The vision is very much in sync with what we've been talking about for the last 2 days, where we really want patients, as Angela said yesterday, as co-producers of care. And we want to have all of the players in the system have the kind of transparency and tools so that we are delivering appropriate care to people where it is aligned with their preferences. And the way that we do that among PBGH's many activities, we have a lot of measurement and quality activities. One of the things that I do is I have a portfolio of grant-funded projects, the intent of which is to be disruptive. And so what we're doing is taking examples. Most of them are high cost, high variation. And we're going right out and partnering with the delivery system and with our health plans to try to see if we can change how things are done and to see what works. People ask what purchasers are looking for, and this is pretty common sense. It falls into 3 bins. Affordability, I guess we're not supposed to talk about cost, but that is actually important, but with a focus on appropriate use. Accountability, with ACOs, we're hearing a lot more talk about that, but and that's really nice. And we want the patients to be engaged, and we want there to be care that's delivered based on evidence. I'm not sure. We submitted these talks about a week ago. And so I think I'll move quickly through this because we've heard a lot about this. But as PBGH members as we looked at what are the high cost, high variation procedures, and Jeff was saying it depends a lot on which kind of purchaser you're talking about. So the retailers, this is a case study about the retailers, where we do have a lot of people who are having a lot of babies. We see that the C-section rates are going up. We see that the quality from those C-sections is often worse, and we see that it costs more. So that's a big focus for us. We also have other employers where it's a manufacturing population, and as Jeff said, they have a lot of hips and knees being replaced, so different topics. This is something, Maureen's not talking today, but the Listening to Mothers survey, the latest one, just came out. And this really starts to relate back to shared decision making. So we have all of these C-sections taking place. The evidence doesn't necessarily support it. And when you ask the women about it, it sounds like they weren't quite as involved as we'd hoped them to be. And looking at the last point here, it echoes a lot of what we were hearing yesterday about women holding back from asking questions because it's uncomfortable. So the purchasers do care about that. What we're doing, I'm going to talk briefly about what we're doing in 4 areas, and they're not all up on this slide, and then I'll show you the results of a survey that we did about what do purchasers think about, what do they think shared decision making is. But what we're doing directly, we are so excited that the Foundation and Childbirth Connections are going to have 3 tools for maternity care coming out, and we are waiting with bated breath to support that. In the meantime, we are doing some bundled payment with quality improvement in the area of maternity care in California, and we're hoping that that starts to address the issue of C-sections, and we're hoping that through the quality improvement activities that we increase the amount of dialogue between the provider and the patient. In orthopedics, we're in the second year of a study that we've been doing with UCSF and Stanford with support from Robert Wood Johnson, where we're engaging the delivery system and the patients and the purchasers in a demonstration about what happens when you take patients who are candidates for hip and knee replacement and expose them and take them through shared decision making. We talk to our health plan partners, as Marcus can tell you, all the time about these things. And we have one really nice example that veers out of traditional shared decision making, but more into the what others were talking about managing patients with multiple chronic conditions. We have Boeing started something called the Ambulatory Intensive Care Unit, which is basically taking patients with multiple medical conditions and putting them in case management. So giving them a personal coach, doing patient activation work, and really partnering with them around their care. And we've taken the Boeing model and we spread it with Anthem's help up in Humboldt County, where it's been very successful with a bunch of CalPERS and PG&E members. And we now have a grant from CMMI to be spreading that in Medicare through 19 practices throughout California. So we do like to go out there and demonstrate things. The last thing that I was talking about briefly last night, which isn't really our project, but we were very glad to be involved in, is Humboldt County took the variation data that has recently come out and engaged a community, a patient group in the community, the whole provider system up there, and some of the employers that are very small, and they're trying to have a community-wide demonstration project to address the variation by using shared decision-making tools, and that's really exciting to see. When I started working in this space, I went out to our members and I asked them, so do you do shared decision-making, and what do you think shared decision-making is? And just as people were saying yesterday, you ask one, you're asking one, and there's a wide variety of definitions of it. A quarter of them offer formal shared decision-making programs, and most of those do that through their health plans. But then they do all of these other things that are all around patient engagement, and in some form are shared decision-making. Everybody has online decision support. Most have telephonic nurse support. Some have second opinions. You're right, they're usually from Boston. Most of the health plans have great online cost calculators and comparison tools, and everybody offers wellness and educational programs, and some of them actually have on-site clinics that provide direct care, and that includes coaching. So that's what purchasers, at least PBGH members, think shared decision-making is. And they believe that it works. And so basically we asked them what they thought it did, and they all thought that it would lead to more appropriate treatment decisions and improve the decision quality, and they thought it would have the potential to reduce expensive procedures. And surprisingly, my hypothesis would have been that people thought that the bottom line cost savings were one of the biggest things they would expect, and that was not. That's the bar the farthest to the right. And then I asked them, how do you evaluate this? How do you know if it's working? And pretty much this is common sense. How engaged are their employees? Is their health improving? And is the cost going down? Then we said, well, whose job is this? And they said, well, we expect the providers to do it. It's part of their job. It's part of appropriate care. And then we said, and they said, well, and we expect our health plan partners really to support this because they're one of the biggest channels for patient engagement. And then we said, well, so, and what's your role in it? And they said, well, we can play a supporting role. And I think that going back to these kinds of things, I think that this is what the traditional purchaser would see as a way that they could support shared decision making. then I think the last thing is, if we're lucky enough to have the PBGH members of the world who are willing to go out and do demonstration projects and try things, that's another role that they can play that's not on this slide. And I think that's about it. I think a lot of what I was going to say got said over the last 2 days, so I'll look forward to your questions.
Well, thanks to all of you. So I think possibly because we're at the end of a wonderful two-day conference, all of you clearly are tired of talking about the sinkhole and tired about talking about the barriers. So mostly you talked about enablers, which is good. You talked about basically paving the road over and getting to a point where we are using shared decision-making much more broadly. And just to recap what all of you said in various ways, I think, Jeff, you identified policy leadership as being one important factor here. And by policy, I gather you meant policy of healthcare organizations, policies of employer groups like PBGH, et cetera. Policy leadership needs to step up to the plate and say, this is the direction we want to go in. A number of you talked about the need to increase the number of decision aids and tools and connect them with more evidence. And once again, Jeff, you used the example, why don't we have decision aids for vaccinations and lots of things now that we know people are just not using the evidence in which to make decisions on. We talked about a number of incentives who would, throughout actors in the system that would motivate them more to use shared decision-making strategies. Clearly, tying shared decision-making more to liability reform would be a big one. That would be a huge incentive for physicians to do more of this. Patient incentives, such as value-based insurance design strategies, as you said, Jeff, would be very important. All of you talked about ways to move this out of the immediate domain of physicians alone, to basically get that out. One of you used the phrase, getting this out into the home, getting it out of the physician visit, the physician encounter, using more health coaches and other non-physician providers to stimulate this, essentially transferring the shared decision-making, Lisa, I think this was your phrase, from the patient time, the patient encounter to the home. So why glom up the works in the office visit with this when you could do this on a non-real-time basis? You all talked about the need to educate physicians more and familiarize them more with this. That obviously would be very important. You talked about building the systems around the physicians to support this and make it really the default decision of physicians to use these tools, these strategies. So again, whether it is computerized physician order entry systems that have the decision aid order built right into them, other ways of optimizing the workflow and integrating the tools right into the clinical workflow. And then finally, you talked about the importance of measuring and monitoring all of this, basically capturing the notion that patients really do like this and value the experience of having gone through shared decision-making, and constantly measuring that and feeding that back to physicians as a way to continue to build their confidence that this really was what patients wanted, that they really were providing optimal patient care. So with that, we have just about 10 minutes, Michael tells me, for additional comments, questions, observations. Obviously, we're now in a point where we're synthesizing and to some degree repeating a lot of what has already been said the last couple of days. But please, we welcome additional comments, and the panel will respond as appropriate. So please start.
Hi, that was a great panel. Thank you. David from Mercy, you emphasized the intense role of health coaches, and I have two questions for you on that. The first is, you mentioned that they had to develop their own software to kind of take care of their shared decision-making process. I'm curious as to if you could explain why the EHR wasn't sufficiently supportive of that, and if you could link that software that you created de novo into your EHR so you could track that. And my second question for you is, what level of training did your health coaches come to you with? I understand you did a lot of training of them because they have an enormous amount of responsibility, but were they RNs or what clinical training did they have when they came to you?
Well, first on the electronic medical record, we're on Allscripts for our electronic medical record. Unfortunately, I had great hopes that the electronic medical record was going to embed all these new care processes electronically and make it how we did our business. The electronic medical record took our old paper chart and made it an electronic chart and didn't really change too much of the care processes, at least not anywhere near where I thought. Our electronic medical record is a national installation. Everything you wanted to change had to go through a committee in Denver, and any decision to make a change took 3 months to make the decision, let alone to implement after the decision was made. The process for embedding this in our electronic medical record just wasn't efficient. We initially did. They built screens for us in the electronic medical record for our health coaches. We finally decided they just didn't work, and we built our own process. The process we have is very interesting. It's built on customer relationship management software. So it's the same kind of stuff that like Nordstrom's used to track their customers. So we're tracking our patients in a similar way that Nordstrom is. I found a very interesting concept, and I got kind of excited about going after that and building our own system based on that software. The training, our coaches all have to be RNs to be chosen, and we have our own training program. We licensed it for a couple of years to the Healthcare Advisory Board company, and then that contract came up, and we took it back, and we have our own training program we do.
Great. Let's take a question over here.
Hi, I'm Kathy Norman from Enterprise Patient Advisory Council. Thank you for including me in this. I have two questions. One is for David Downs. You talked a lot about getting it out to the community, and I'm wondering if you would define community. Do you mean community outside of clinics and doctors and hospitals, and if so, how do you plan on doing it? My other question maybe is to everybody is, as a patient consumer, I'm really offended by the number of pharmaceutical ads on TV, and I see that, especially with elderly patients, is just more confusion for them when it says, go ask your doctor. I would think that would be very time-consuming for doctors who are already dealing with a difficult population. I was wondering if you could address those two issues for me.
Yeah, as far as communities go, the first issue is to define a community that you're going to go into. And so one of the reasons we chose the San Luis Valley is just because it's very well geographically defined. It's very easy to outreach to the providers because most of them are employed by one of two entities. Now that we're seeing Medicaid in Colorado being divided into 7 different distinct regions, there is coming to be some infrastructure for communication with doctors there. I think with regard to shared decision-making, it's critical to identify a cohort of physicians that can execute on it and that are available for training and delivery of curriculum. So that's kind of where we're starting. What we're hoping for is to see a culture change that kind of spreads beyond those initial pilot communities, so that there comes to be an expectation and patients just begin to expect to have these kinds of resources available to them when they seek care. I'm also hopeful, the internet is going to be, I think, one strategy for expanding that. The only thing I worry about is that when people go on the internet, they tend to surf back and forth and not stay in one place for very long. I am hopeful that patients that are seeking this kind of information are going to be highly invested in it and probably will stick in one place for that. But I think that's another strategy for expanding to a community. What we'd like to do is develop a regional resource center for shared decision-making, and that would provide the decision aids. It would provide public outreach. Our firm does a lot of kind of organizing communities around policy issues, and so hopefully using some of that infrastructure will work. As far as the advertisements, the pharmaceutical industry, when they advertise, has one of two choices. They can give the drug and they can start going through that laundry list of all the horrible things that will happen to you if you actually take it. Or they can say, go talk to your doctor to get that off their back. And it is kind of bothersome, frankly.
Is there a way to get that off of the airways?
No. No, I think, we live in a democracy that is capitalism, and we've decided that, our pension funds, are brought to you by, many pharmaceutical industries, and they need to make a profit. I think, from a policy standpoint, do you contract with physicians or groups that don't allow pharmaceutical reps into their facilities? That's a question you could ask, But the reality is that, it's probably not going to change fast.
Thank you. And that unfortunately may be another conference in and of itself. So.
There's only one thing worse than pharmaceutical ads, I think, is institutional ads advertising inappropriate services. So just an editorial comment.
You might want to say a phrase about what you're referring to, Dan, there, posters of hospitals.
Oh, I wrote a blog, a pitch from my blog about an undisclosed institution in Philadelphia advertising proton therapy, saying it was more effective. It is more effective for children with cancer and eye problems, but not anything else. And of course, it showed somebody riding a bicycle, saying you could be as free as this, So, anyways, it cost about 10 times as much as the alternative therapy, and it was an AMC, which I think is unethical. Anyways, that's not what I wanted to talk about. I wanted to talk about this phrase of affordability, which I think is probably a better phrase than cost. By the way, the stuff about cost came out of many focus groups and huge surveys saying that cost is not the way to talk. But I have a question for...
To patients.
To physicians.
Well, right.
If you want to engage them...
But particularly to patients.
Well, particularly, but we didn't survey that. We surveyed physicians. And it was not the way to engage them in thinking about affordability or appropriateness. So I have a question for Lisa. So Lisa, you and I want you to draw some dots for me. So episodes of care has lots of policy implications for this town. That's how Medicare will begin to look at quality or cost or efficiency. And of course, it drives me nuts because it all assumes that all episodes are appropriate, and we know that that's not true. So you're looking at episodes, and I don't see you looking at, and maybe you are, and I want to hear about it, appropriateness, and then you just to position that talk with shared decision making. So draw some dots for me about episodes of care and shared decision making, because I didn't get it.
So that was actually my point. Is this on? You guys can hear me? Oh, there we go. That was actually my point when I was making that connection from where we started, which was just a pilot. We were just doing a pilot to make sure we could all combine our data, and we decided that using a total knee replacement episode was the cleanest, easiest thing to start with as a new collaborative who'd never shared data before. But that was my little joke about Jack saying we were low-value collaborative, because that was the Health Affairs article. So we really needed to get to that second part of the equation, which was a much more important part, which was the appropriateness piece. And that is what led us to the focus on the rates of certain procedures and the appropriateness of the care and that variation across that spectrum. So that was the dot. That was the connection. And actually, can I, while I have the mic, say one more thing that I think is really important, because this is the piece to the sustainability and affordability, in my mind, of trying to make this a broad disruptive implementation across the country. I don't know if I gave enough credit to my foundation friends, Richard Wexler. I know I didn't name you, so I want to make sure I said Richard Wexler and Meg and Julie behind the scenes, and of course Mike and Karen and others, in helping us develop a really, really robust training program, that's long-distance training program, and a web-based toolkit, so that people can really figure out over time. We're not going to be able to handhold everybody, and I know all these demonstration projects have been great, but this this will, I think, over time, give us the ability to really be able to spread in a more effective way. You guys have been awesome.
AHRQ recently published a report of all of our 30 years of episodes of care and bundling and DRGs, and the bottom line was we're not sure how much cost it saved, and we didn't do anything on quality. So my point to you is where shared decision-making comes in, I think we really need to put the evidence in. Let's take back surgery. If you're going to do a discectomy, you've got microdiscectomy, open discectomy, PAP pain, IDAT, blah, blah. It really would be nice to see a shared decision-making, like I said, ABCD. What are the likelihoods of outcomes? And then really give it to the client to say, okay, here's your chances. But that's not what we do. We say, back surgery is this, and then we let the physicians or surgeons do whatever they want. And we don't even talk about the outcomes. So if we could actually do what, the bundle payments and do what Stanford talked about, put the quality in, real quality, readmissions, function, maybe we got a shot. But right now, the quality metrics are pretty diluted.
Who was it who used the phrase, without outcomes, there is no income, as we move the system in that direction?
Another opportunity is just to include validated shared decision-making process as part of the bundle.
Right.
Great. Take a question. Okay, great.
Thank you. I wanted to thank the panel members. This is a very thought-provoking panel, and I think this is probably one of the most important panels in terms of George Boleyn's point of we know these things work, let's get beyond the pilots, let's get them spread. And Bruce's point I want to come back to is why can't we really break out and get this just as you said, it should be an expectation that these things are available. So I have a couple of suggestions for the foundation around that, and maybe you've already thought about this, but I think that there are potential partners out there that could help us to really move this up a notch. One is AARP. Every single one of us that's 50 or above has gotten our AARP free membership card. I'd love to have gotten a decision aid on colon cancer screening along with that card. Or if I were a guy, maybe PSA screening. So, there's a really good potential partner. Another that I thought about was Apple. How about really cheap iPod apps for these things? So $1, for an app on any of these decision aids. And then the third was Netflix. How many of you have Netflix? You can do online streaming, or you can do that really easy turnaround mailer. So there's another possible distribution channel. So just some food for thought for the foundation going forward.
This is great. Al Abraham, Kaiser Permanente. I just wanted to make a comment about the definition of decision aid, because we struggled with that initially, especially in trying to explain to physicians what's so different about a decision aid. And when I saw the definition that I think Jeff used, that it's information about the condition, benefits, the harms, a lot of physicians came back with, we already have that. We already provide that. And it dawned on us that there's a difference between an educational aid and a decision aid. And it wasn't until we put them side by side and explained to doctors that a decision aid goes beyond just the information and begins to interact with the patient to walk them through a process. So the interactive process of the decision aid was very crucial in finally convincing the doctors that this is different. So, and now everywhere I go, I carry that slide and I use it, and it works. Just a comment.
Great. Well, the other thing I think we come back to is that the world is really changing to the degree that the expectation on the part of many patients was that care is only provided when they show up in the doctor's office. We know that that is going away. And just to offer one brief story of that, I spoke recently to the fellow at Qualcomm who runs their healthcare practice. And Qualcomm, as many of you know, is the company that makes the chips in most of the cell phones that we use. But they have a huge healthcare business. This fellow was telling me about his own son, an 18-year-old who has congenital arrhythmia. and was carrying around a device that has been popularized by Eric Topol, among others. It will take it's the size of a phone, and you can put it on your chest and do your own echocardiogram. And he was up in the mountains of Montana and was hiking and had an episode. Basically took his own echocardiogram and emailed it instantly to the hospital 20 miles away and told them to get ready because he would be coming in shortly, and here was the treatment that he needed. So this is the new world of some patients who are extremely enlightened. Not, of course, all of them are, but more savvy, more accustomed to using these kinds of tools. And I think, apropos of the earlier comment, this is going to create many new opportunities to push these kinds of aids out and get them into broader use. So on that note, Michael, do I turn things back over to you or Dominic to close us out?
Our panel.